It's a difficult model to implement because training systems aren't set up to treat complex co-occurring disorders. People who have eating disorder training aren't typically ever getting addiction training, and vice versa. Most people who have addiction training and deep addiction expertise have very little in the way of knowledge, training, experience, helping people recover from eating disorders. So part of what we do here is we devote a fair amount of resources to training staff in the model. And we take people who have, the core values that are important to us and who can live those values with our patients. And most of those people are coming to us with one area of expertise and need to learn how to treat people. An addiction expert, like Shale Marks is a great example of this, came with a lot of addiction experience, deep understanding of addiction as it plays out with alcohol, drugs, prescription drugs, no eating disorder experience. And here, 2 years later, 3 years later, he has a tremendous amount of eating disorder knowledge and experience helping people with both addiction and eating disorders recover from both at the same time. Part of it is training and supervision, which we do a lot of. Part of it is the way that the program itself is built and set up. There isn't a eating disorder program that's like completely different from the substance addiction program, completely different from the PTSD program, and most other places, at least the ones that I'm aware of, are set up in sort of modules or silos. Our patients come in with depression, histories of childhood trauma and abuse, PTSD, cutting, an eating disorder, and a pill addiction. It's a hard population to serve. It's work that can be taxing emotionally, but we're aware of that, and we advocate for our patients with their insurance companies to get length of stays that people with complex co-occurring disorders need, which is typically longer than somebody just coming in for help with an alcohol addiction.